Hello, and thank you for joining the Systems for Action Research in Progress webinar. My name is Chris Lido, Deputy Director of Systems for Action, which is a national research program of the Robert Wood Johnson Foundation, housed at the Colorado School of Public Health. So today we'll hear from an SFRA research team evaluating the effectiveness of California's Whole Person Care, or WPC initiative, in coordinating health and social services for Medicaid beneficiaries with complex needs during the COVID-19 pandemic. So we'll hear from the primary investigators on the project, followed up by some commentary as well. We're reserving about 10 to 15 minutes at the end for Q&A. Feel free to enter any questions that come up during the presentation in the Q&A box at the bottom of your screen. And we'll be sure to reserve some time at the end to have the presenters respond to your question. So now I'll introduce our presenters really quickly. Emmeline Chong is an associate professor in the School of Social Welfare at UC Berkeley and director of the MAC Center on Public and Nonprofit Management and Human Services, and adjunct associate professor in health policy management in the UCLA Fielding School of Public Health. Nadira Porad is the associate center director at the UCLA Center for Health Policy Research and professor of health policy and management at the UCLA Fielding School of Public Health and professor at the UCLA School of Dentistry. And we'll be getting a little commentary from Leanne Haley, who's a project manager and research analyst for the Health Economics and Evaluation Research Program at the UCLA Center for Health Policy Research, or CHPR. And with that, I'll hand over the controls to our presenters for the day. Don't forget to add questions to the Q&A box at the bottom of your screen.
Thank you for the introduction, Chris. I just wanted to say thank you all for joining us today. I just wanted to briefly acknowledge that this work requires a full team, and their names are listed here. I'm not going to go into a ton of detail on it. Oh, do I have? Okay, here we go. So our project is part of the Robert Wood Johnson Foundation Systems for Action portfolio, which is focused on identifying innovative mechanisms for aligning medical care, social service, and public health sectors in collective action. In our case, the funds are supplement to an existing larger evaluation that really lets us extend our work to better understand how the program we're studying, the Medi-Cal Whole Person Care Pilot Program, is functioning in the context of the pandemic. Because it is our funding is supplemental, I will start by briefly describing the program we're studying, sharing some of the select interim evaluation results, and then explaining how our Robert Wood Johnson Foundation funded study will build on and extend this work. Oh, sorry, went a little too fast. So in California, the Medi-Cal Whole Person Care Pilot Program is one of several innovative demonstration projects included within the state section 115A waiver, which allows for flexible use of Medicaid funds to test innovations in service delivery. Under whole person care, collaborative networks of organizations are testing whether flexible use of Medicaid funds to provide care coordination and other non-clinical services not traditionally covered by Medicaid will result in improved health and well-being of eligible beneficiaries involved with multiple service systems. The slide shown here highlights some of the mechanisms that we hypothesize will result in improved outcomes. I'll highlight a couple briefly. One unique aspect is that the funds can be spent not only on services not traditionally covered by Medicaid, but also on developing data sharing and delivery system infrastructure that might be needed to support cross-sector systems alignment. So for example, under the delivery system infrastructure, pilots could spend the funds to develop mobile street teams, build sobering centers as an alternative to incarceration or emergency department use, or develop recuperative care facilities. Another important provision within whole person care is that all pilots had to be implemented by collaborative cross-sector partnerships that included at least one Medicaid managed care plan, one health services agency, one specialty mental health service provider, and one community provider. Though not required, I'll just note most pilots, 15 of 25, also included the county public health department as a partner. And in thinking about the population served by this program, California's Department of Healthcare Services, which administers the state's Medi-Cal program, initially identified 6 different target populations that pilots could choose to serve. They're shown at the bottom of the slide. They include high utilizers of avoidable emergency department or inpatient care, individuals with 2 or more chronic physical conditions, those with severe mental illness or substance use disorders, individuals experiencing homelessness or at risk of homelessness, as well as those recently released from institutions such as jail or prison. Ooh, I don't know why it keeps advancing too. Sorry about that. So currently there's 25 different whole person care pilot programs that collectively represent 26 counties in California. An important point to keep in mind is that in implementing whole person care, these pilots had really considerable flexibility in tailoring their programs to reflect differences in local resources and needs. And this resulted in considerable heterogeneity across pilots and selected target populations, outreach methods, type and intensity of services provided. As an example of some of this, projected 5-year enrollment targets range from 250 in one of the smaller counties to over 150,000 in another, Los Angeles. Similarly, approved 5-year budgets ranged from just under 5 million in, again, the same slightly smaller county to 1.26 billion in Los Angeles. Pilots had a planning year and began enrolling eligible beneficiaries in January of 2017. In thinking about pandemic impact, the program was originally scheduled. Oh, Nadi, did you?
No, sorry, I didn't realize I'm not muted.
Oh, it's okay. I just wanted to make sure you could chime in if you needed. So in thinking about pandemic impact, the program was originally scheduled to run from 2016 to 2020, but was subsequently extended for a year due to the pandemic. In mid-2020, pilots also had the option of expanding services to a new target population of individuals impacted by COVID, defined pretty broadly by the state as those at risk of contracting COVID, having contracted COVID, or in recovery from COVID. Review of alternative budget narratives submitted to the state in 2020 suggested that at that time, the majority of pilots, 17 of 25 or 68%, plan to provide services to this new target population. And part of what our new data collection efforts in 2021 will focus on is what was actually done here. So, as I mentioned previously, our study is a supplement to a larger evaluation. Our team, led by Dr. Porad, is responsible for the state evaluation of the whole person care pilot program, which is focused on understanding the extent to which whole person care improves enrollees' access to needed services, reduces inappropriate emergency department and inpatient utilization, and improves health and well-being for enrollees. As a result, our Robert Wood Johnson Foundation study really benefits from rich mixed methods data already being collected as part of the larger evaluation. In the next few slides, I'll report on some of the interim evaluation results that will hopefully provide you with a little bit more insight into what whole person care entails, as well as some preliminary evidence of the program's effectiveness before the pandemic. So, the whole person care pilot program, as originally designed, did not actually include an explicit focus on improving health equity. And as such, our broader evaluation also didn't assess whether whole person care enrollment, service utilization, and outcomes varied across different demographic groups. However, preliminary analyses do indicate that during the first 2 years of the program, almost 105,000 unique Medi-Cal beneficiaries were enrolled, and of these, 28% were white, 25% were African American, 23% were Hispanic Latino, and close to half of enrollees, 44%, were homeless. With regards to some of the variation in services provided, pilots were required to provide care coordination and later housing support, but other services were optional. And even within these broad categories of care coordination and housing support, there was considerable heterogeneity in what pilots actually chose to provide. that I'll highlight in a little bit more detail in a later slide. At least in the housing services arena, analysis of qualitative data show, for example, that 23 of 25 pilots reported using a housing first approach that prioritizes provision of permanent housing without requiring enrollees to first address behavioral health problems or graduate from other service programs first. As you can see in this figure, many pilots also reported directly providing other services such as employment assistance, sobering center stays or medical respite services, benefits assistance, which was very broadly defined as any services focused on helping enrollees access or maintain benefits. So this can include not only assistance with applying for benefits such as supplemental security income or social security disability assistance, Medi-Cal, CalFresh, CalWorks, but also transport to appointments or providing temporary phones or childcare. I mentioned before heterogeneity in care coordination services. This figure provides a brief snapshot of a little bit of what I mean by that. In our 2018-29 interviews with key informants in these pilots, we quickly identified considerable heterogeneity in how care coordination was being defined, and we followed up on that in more detail in a subsequent survey. We found all pilots reported plans to conduct a comprehensive needs assessment and care plan for enrollees within 30 days of enrollment, but there was otherwise a fair amount of variation in the kinds of activities that pilots engaged in, with some providing services that really looked more like intensive care management, such as providing education or coaching around self-management or providing medication management assistance. For those of you that are interested in learning a little bit more on the care coordination, I've included a link at the bottom of this slide to a publication that provides more detailed information regarding specific care coordination infrastructure and processes implemented by the pilots, including things like the staffing model they used, caseload, average caseload for care coordination staff, and data sharing capabilities used to support care coordination activities, as well as the actual care coordination processes. Finally, I think this is often of interest. In a 2020 organizational survey, we also looked more systematically at the specific social needs being assessed, as well as assessment approaches and tools being used. This slide shows some of the preliminary results. For example, all pilots assessed housing needs. Most looked at needs for other public benefits, transportation, food security, and most also looked at interpersonal safety. I got a couple comments that there's interest in having some of the links placed directly in the chat. Leanne or Brenna, if you're available, is that something you'd be willing to help with?
Yes, we can do that.
Thank you. And analyses of our 2018 and 2019 key informant interviews and surveys also found that all pilots, at least over the first couple years, reported significant improvements in data sharing and delivery system infrastructure and in care coordination processes needed to identify and address enrollees' complex needs. As you might expect, we also identified a number of early challenges and lessons learned experienced by pilots in implementing whole person care. For example, some of the challenges experienced in identifying and engaging eligible beneficiaries and services. And we also highlighted some strategies that pilots used to overcome these challenges. I've included a snapshot of some of these here in the slide. So for example, 80% of pilots reported challenges in identifying eligible beneficiaries. And then I've also outlined some of the strategies that they used, but a fuller discussion is available in a 2020 Health Affairs article, which I've included, again, a link for at the bottom of this slide, and we'll try to get that in the chat for those who are interested in kind of diving more into that area. And then in thinking about the program's impact on enrollee outcomes, interim analyses from the first 2 years of the program demonstrate some early successes in improving enrollee access to certain types of care and in improving certain outcomes of care. So for example, we found that rates of initiation engagement in alcohol and other drug dependence treatment increased for enrollees following enrollment in whole person care, and that these increases were larger for enrollees than a matched control group of Medi-Cal beneficiaries that weren't enrolled in the program. Similarly, there's some evidence that whole person care succeeded in preventing emergency department or hospitalizations for enrollees compared to the control group. And though not shown in this slide, but available in a fuller report that again, I've included a link for those who are interested, we found that emergency department visits and all-cause readmissions decline more for whole person care enrollees compared to the control group from the first to second year of enrollment. Again, there's a lot more results. I think I could spend the whole hour talking about those, but for those who are interested in at least the early interim results from the program, we've included a link to the fuller interim evaluation report, which is publicly available. So I think of greatest relevance to the Robert Wood Johnson Foundation study, thinking about whole person care and how it was impacted by the pandemic. In California, a statewide shelter-in-place order was enacted on March 19th in 2020. And in early April, we conducted a preliminary rapid response survey of pilots to assess ways in which counties may have leveraged whole person care resources to inform their pandemic response, as well as better understand how the pandemic was impacting implementation of the program. So perhaps unsurprisingly, we found that early in the pandemic, many but not all pilots reported shifting processes for identifying and enrolling eligible beneficiaries to telephonic or other remote approaches, which many pilots perceived as really limiting their ability to effectively engage homeless and recently incarcerated populations in care. More promisingly, we also learned that many pilots described relying a lot on the interagency relationships, data sharing infrastructure, and other resources developed as part of the program to help coordinate their local pandemic response. So, for example, a few pilots reported temporary reassignment of whole person care staff to support surge planning and infection control efforts and converting beds previously used, for example, for recuperative care or sobering center stays to expand hospital capacity for COVID patients or to house enrollees needing a safe space to shelter in place. Preliminary analyses of 2020 narrative reports indicate that many partner organizations collaborated on how to best serve shared homeless clients, including prioritizing whole person care client access to COVID shelters or developing new rapid emergency housing for enrollees. But longer term impacts of the pandemic are unknown and are part of what we are proposing to examine as part of our Robert Wood Johnson Foundation study. While we anticipate that, the infrastructure and care processes from whole person care will continue to improve outcomes for enrollees, even in the context of the pandemic, this study will allow us to really test this empirically and also address implications for health equity by testing whether the pandemic's impact on enrollment, service utilization, and outcomes varies across demographic groups. So that brings me to the actual aims for our Robert Wood Johnson Foundation study. As I mentioned before, aim 1 is really to look at whether the impact of the pandemic on whole person care enrollment, service utilization, and outcomes varies across different demographic groups. Second, to assess changes in whole person care pilot partnerships in response to the pandemic. And third, to examine pilot level characteristics that are associated with improved outcomes for whole person care enrollees in the context of the pandemic. And I'll talk a little bit more about what we're going to do in relation to each study aim in the following slides. So in regards to this first aim, does impact of the pandemic on enrollment, service utilization, and outcomes vary across demographic groups? To address this aim, we're planning to draw on enrollment data, monthly enrollment and utilization reports submitted by pilots to the state. Service utilization and outcome measures will be drawn from a combination of Medicaid claims and enrollment data and pilot reported performance metrics. Specific service utilization measures we plan to look at are things like receipt of care coordination, operationalizes whether enrollees actually got a comprehensive care plan within 30 days of enrollment, as well as their utilization of primary care, substance abuse treatment, or housing support services. For outcomes, we propose to focus primarily on 4 key indicators of enrollee health and well-being: emergency department visits, hospitalizations, and readmissions, as well as enrollee well-being. And the demographic characteristics that we'll be looking at include gender as well as race and ethnicity. In terms of specific approach, our current plan, which we welcome input and feedback on, is to use difference in difference models to compare enrollment, utilization, and outcomes for different demographic groups during the pandemic as opposed to pre-pandemic. Our models that examine health outcomes will include a matched comparison group. In terms of aim 2, assess changes in whole person care partnerships in response to the pandemic. Prior research suggests that coordinated service delivery across inter-organizational networks is really important for effectively meeting the needs of individuals with complex medical, behavioral health, or social needs. But these kinds of networks can be really difficult to develop or sustain, and engagement of organizational partners is often relatively shallow. Currently, relatively little is known about factors influencing effectiveness of these kinds of cross-sector partnerships, particularly when financial barriers to collaboration are removed, as is in the case to some extent with this program. So in whole person care, we believe the requirements that pilots be implemented by collaborative cross-sector partnerships represents a unique opportunity for us to look at network or partnership characteristics associated with differential response to the pandemic, as well as greater pilot level improvements in enrollee health and well-being. So for AIM-2, we propose to use a combination of social network analysis and multiple case study analysis to really look at what's happening with these partnerships in response to the pandemic. Qualitative interviews that we conducted in 2018 and 2019, and that we propose to conduct again in 2021. Projected timeline is sort of in the May to July timeframe. We'll provide information on whole person care pilot program implementation, as well as specific changes that have occurred as a result of the pandemic, including modifications made to serve the new COVID-19 target population. And we also plan to draw on data from organizational surveys administered in 2018 and 2020 that more systematically assess changes in data sharing and delivery system infrastructure, as well as to partner networks. So as an example, in these surveys, respondents were provided a roster of all participating entities in their pilot and really asked to indicate how their organization collaborated with each entity at 3 points in time, prior to whole person care, mid-implementation. So again, that's in the 2018 to 2019 timeframe, as well as during the pandemic. And the specific kinds of ties we have assessed at all 3 time points include things like not only referrals, but data sharing, joint advocacy or planning, communication about client needs or care, or joint service delivery. I'll just give you a little bit of a snapshot of some of the data that we have in case you're curious. So these data just look at what was happening in these partnerships prior to whole person care and at mid-implementation in 2018, 2019. You can see on average, we're seeing increases in the kinds of ways that these partners are collaborating. I've shown here also, just for those who are curious, when we think about the types of human service agency partners that are involved in pilots, you can see 60% of pilots included the County Housing Authority, 76% included local probation departments, and 64%, for example, included the County Human Service Agency. Looking deeper at some of the specific strategies being used to promote health and social services integration, you'll see the majority are including their social service partners in joint decision-making and data sharing, as well as incorporating them in multidisciplinary teams. Co-location, cross-training, and joint budgeting are less common, but are happening in some of the pilots. And finally, just looking at AIM-3, identifying pilot level characteristics associated with improved outcomes for whole person care enrollees in the context of the pandemic. In this case, our unit of analysis is at the pilot level, and in terms of improved outcomes, again, our intent is to use results of difference and difference analyses already being conducted as part of the broader evaluation, as well as in AIM-1, to differentiate pilots that successfully improved outcomes overall and for specific demographic groups from those that did not. We plan to use, t-test or Pearson's chi-square test to compare the means of pilot level characteristics in pilots that successfully improved health and well-being and those that didn't. And then our sort of plan A is to use a configurational comparative method known as qualitative comparative analysis to really identify specific combinations of pilot level characteristics associated with improved enrollee outcomes. Shown on the right of this slide is just some examples of the pilot level characteristics that we hypothesize will play a role in influencing outcomes, in addition to, for example, type and intensity of services actually provided to enrollees. So we'll be looking at the pilot's governance structure, the extent to which their lead entity governed, for example, versus really using more of a shared governance approach, the quality of the relationship, some of those network measures, as well as the quality of care coordination provided, among others. In the event that QCA doesn't work out, we'll rely primarily on comparative case study analysis instead. In terms of the relevance of this work, normally we would be asked to bring in a commentator. Just given the time frame, we weren't able to do this. Oh, I went too far on the slides. I wanted to talk nationally first. Excuse me while I go back. So, nationally, there is increased health policymaker and payer interest in programs that effectively identify and address medical and non-medical needs of clients. And in particular, there's increasing interest in what state Medicaid programs can do to identify and address social determinants of health. In 2020, the Kaiser Family Foundation published an issue brief that shows that currently more than half of states have contract requirements requiring managed care plans to screen enrollees for social needs and refer them. And many also require partnerships with community-based organizations or other social service providers. And our hope is that findings from our study in terms of what works and partnering with other entities to address Medicaid beneficiaries' clinical and non-clinical needs may be useful for this conversation. In California specifically, I'd like to talk a little bit about the relevance of this work. Since 2016, California has engaged in multiple demonstration projects that are intended to inform the new strategic direction for its Medicaid program. Pallame, which stands for California Advancing and Innovating Medi-Cal, is a new planned multi-year initiative by the California Department of Healthcare Services that entails a fairly broad vision for delivery system, program, and payment reform across its Medicaid program. The Pallame was originally supposed to begin implementation in January 2021, but was delayed for a year due to the pandemic. Some of the major goals of Pallame include identifying and managing member risk and need through a whole person care approach and addressing social determinants of health, reducing complexity and increasing flexibility within its Medicaid program, and using value-based initiatives, systems modernization, and payment reform to really transform delivery systems in ways that improve quality outcomes and reduce disparities. Specific elements of Pallame that are very relevant in looking at what's happening with whole person care include the introduction of a new enhanced care management benefit that basically incentivizes addressing clinical and non-clinical needs of high-risk Medi-Cal beneficiaries that builds on both whole person care as well as another sort of parallel pilot program that the state has been running called Medi-Cal Health Homes. And as well as the new in lieu of services and incentive payment benefit, which is flexible wraparound services that managed care plans can integrate into their population health strategy. And basically the intent is for funds to be flexibly used to basically provide services that are not traditionally covered by Medicaid, but could help high-risk members. And so examples of the kinds of services that we'll be talking about in lieu of services would be things like housing-related services, such as housing tenancy, housing navigation, long-term care supports and services, and diversion-related services like sobering center stays. And so as Medi-Cal managed care plans are considering what they may offer as part of Pallame, they're currently I think due to submit plans to the state in July. I think there's a lot of interest in how learnings from whole person care as well as Medi-Cal Health Homes can inform what they propose to do. And so when we think about the relevance of this work, both nationally and in California, I think that there's implications there. I saw a lot of questions popping up in the chat. I wanted to provide a little bit of an overview, but also leave plenty of time to address specific questions that folks may have about the program. And so wanted to throw it open for Q&A.
I could start by answering one of the questions that was posted in Q&A about whether we are looking at COVID long haulers, people who have long-term issues. And I think for the evaluation, as well as the RWJ grant, we could, but our ability to identify long haulers would really depend on the coding. of these conditions in the claims. So to the degree that that information is available, we could look at it. It's not something that we have made specific plans for, because early in the pandemic, those codes were not even available in order to accurately identify people with COVID. So we actually have to wait for those claims data to arrive to have a careful look at what's possible and what's not possible.
Okay, thank you. Makes sense. So thank you, Emily, for the in-depth presentation. And we'll move right along to Q&A in this next 15-20 minutes. Some were already responded to, but I'll go ahead and ask them for benefit of the rest of the group. All right. So the first question we have, or the next question we have, rather, is from David. Would like to know, how are you specifically measuring enrollee well-being? And I'll tag on a related question from Glenn. Are you interviewing service recipients to gauge how well they think their goals and needs are being met as a result of these changes from the person perspectives?
And you want me to take that?
So I'll start by answering the corollary question, and then I think the answer to how we could measure enrollee well-being is a little bit lengthier, and I'll punt it to Nadi and Brenna to dive in. Unfortunately, evaluation resources do not allow us to directly interview service recipients to gauge how well they think their goals and needs are being met. I know that pilots vary in the extent to which they're directly collecting that data. With support from one of our research assistants and a doctoral student on the project, we are collecting newer data in 2021 related to the extent to which pilots used a community engaged approach in designing the program, implementing the program, and in getting feedback about the program. And so at least we plan to be collecting some of that information more systematically. Some of it came out already in some of our interim results, but we're planning to look at it more systematically in 2021.
So we're not actually, I think when you ask the question about well-being, it depends what exactly are you thinking about. The evaluation uses two types of data: information about program implementation, which is essentially lots of different surveys and interviews with those that are participating in delivering services or planning the program. And then the other sort of data is all of the Medi-Cal enrollment and claims data, or Medicaid. So we are essentially trying to examine changes in indicators of health, that what you can glean from utilization. I know it is not ideal, but that's what we are limited to. Claims data do not give you adequate information about the outcomes of care in terms of, do people that actually receive, let's say, services for mental health have improved mental health status? It doesn't really get you that kind of information. So we are restricted in those areas, and we're doing the best we can with the data that's available to us.
Fantastic. Emily, were you about to chime in? I saw you took yourself off mute.
Oh, I was just continuing to look at some of the questions, and I didn't know if Brenna or Leanne wanted to elaborate on the well-being bit before we tackled the next one.
Okay.
All right, I'll move on. I think. Oh,
sorry. Yeah. Yeah, so the measure of well-being was just self-reported from the beneficiaries, just self-reported to the question in general, how would you rate your health? And then how would you rate your emotional and mental health? So pretty straightforward.
Yeah.
Okay, and the next question is a little more specific. How are, Gilbert would like to know, how are payments organized to non-clinicians under the 1115 waiver? Is it a capitated payment? Are there other incentives to work across payments silos?
And so this gets a little bit complicated, and I'll give a very broad answer. We are doing some ancillary work, diving into this a little bit more. And so basically, wow, it is very complicated. So pilots really varied in how they structured some of the payments and how they got distributed to partners. And so typically with these partnerships, there's a single lead entity that's designated as responsible as having primary responsibility for implementation and reporting to the state. And they're also sort of the primary entity that the funds from the state go to. That said, when it comes to how payments then get passed on to partner entities to incentivize engagement, work on infrastructure, provide services, there's tremendous variation. Some services, yes, are paid through capitated bundles. And some of them are risk stratified, some aren't. Some are actually covered through fee for service. And there's also, because of the ability to develop infrastructure, what you also see is sometimes incentive payments for partners to do things like participate in meetings or, meet certain kinds of infrastructure development goals or facilitate that. And every pilot structured it a little bit differently. And so that's sort of an ancillary study all of its own. And I would say it varies a lot by pilot.
Let me add a distinction here between what is paid to providers who deliver healthcare or behavioral health services under Medi-Cal versus what is paid to lead entities that are delivering whole person care services. So there are two different things. The program is clear that the whole person care services are not for the kinds of things that a provider would typically bill Medicaid for. So if a provider is delivering a medical visit, that's billed under the program, under Medicaid, program separately. Whole person care is all of these wraparound and additional services that the program's providing. They are not those kinds of, so for example, one of the things that Em just mentioned, which is fee for service, is respite care. Respite care is not a Medicaid benefit. So the program is paying for that under this demonstration to see how it works, to see how effective it is in keeping patients out of hospitals and ED.
Great, thank you for those responses. The next question is from Ian. They'd like to know, has the Pathways Community Hub model been used in any of the pilots, to your knowledge?
So it's probably a pause while we all kind of look at what is entailed in the Pathways Community Hub model. And I just took a quick skim, and what I would say is when we think about what's happening with the pilots, many of them do use community health workers or other sort of staff with shared lived experience with enrollees to help build engagement and trust or engage in outreach. Some pilots varied considerably in exactly what they did. Some are using a hub approach, but I think we would need to actually do some digging to see if it's the Pathways Community Hub model specifically. So it's not something we can immediately answer. I think we would need to do a little bit more digging. Sorry about that.
Okay. And I think, so Alexandra has a question, and I think Nadira is clarifying, but, oh, okay, disappeared on me. Nadia, do you want to share that question that you just responded to?
I should unmute. It disappeared on me, so I need to find it again. I think there was a question on clarifying the difference between whole person care services and general Medicaid services, and whether physicians are still involved. I was saying what you could see if you look at the document that one of the links that we shared. We talked about the teams of individuals that are involved in whole person care services. So physicians are not delivering medical care directly as a whole person care service, but they are still involved in teams that determine what are the whole person care needs of a patient and what they need. For example, if a person needs linkages between medical care and behavioral health care, physicians could still be involved in determining the needs of the patient and offering, options and suggestions, but they're not delivering direct medical care. Hopefully that clarifies the question.
And what you see in some pilots, I'll just add on, what you see in some pilots is that, they may have just 20% of a physician covered under whole person care. And what may happen is that, they're billing for the traditional medical care provided, and then a portion of the physician's time is, dedicated to providing and supporting some of what's happening with whole person care. Does that make sense? So it depends on the pilot and how innovative, they varied in the extent to which they did some of that braided funding versus really carved whole person care out as something very separate.
I think there's a question on the chat about pandemic-driven communication changes that have improved coordination among providers. I don't believe we have heard anything among providers, but one thing we heard from pilots was that the fact that people were isolated at home actually increased communication with some of the enrollees much better, because they had time and they were available to talk with their care coordinators. But I don't know if there's anything else you wanted to add about provider communications.
So what I would say is, part of what we hope to look at explicitly is, we know in some cases, a lot of the data sharing infrastructure that pilots were able to develop before the pandemic, right, was really helping create an infrastructure that could facilitate provider communication that wasn't there before. And I think part of what we're hoping to look at as part of this grant is the extent to which those kinds of benefits were maintained, changed as a result of the pandemic, but we don't have direct data at that level yet. That's part of what we plan to collect in 2021.
Awesome. So one other question I'd like to ask, what are the target populations for the new enhanced care management benefit? And is the benefit structured to provide flexibility for paying for supportive services like supportive housing? I saw that Leanne had added a tool for that. And I was just wondering if you all could talk on that a bit.
Yeah, so I added a link to the guidelines for Pallame, which outline the target populations. So a lot of the target populations are similar to those for whole person care. So those that are homeless or at risk of homelessness, high utilizers, multiple chronic conditions, that sort of thing. And then what was the second part of your question, Chris?
Sorry, I just lost it. Okay, so the second part of the question is whether the benefit is structured to provide flexibility for paying for supportive services such as supportive housing.
I believe so. Nadi, you might be more familiar with that for Pallame. Sorry, that's a different program, but it's what like whole person care is eventually sort of transitioning to, if you will.
Sorry, I was busy typing something and I didn't hear the question. Sorry, Chris.
Yeah, so the question in its entirety was, where are the target populations for the new enhanced care management benefit? And is the benefit structured to provide flexibility for paying for supportive services like supporting housing, for example, supportive housing?
I think the intention of Pallame and enhanced care management, that what the state's doing is taking the whole person care demonstration, which essentially added these additional care coordination and housing support services, plus some of the other things that the in lieu of services, they call it, some of those services that are typically are not covered by Medi-Cal as a benefit. So whole person care does that. And then there's this other program, Health Home, that Em mentioned, that is doing something similar, but slightly different because it's using a different mechanism. It's using the health plans to deliver these services through different contractual arrangements. But the intent is essentially to help people that need these social services. Part of it is social service. The other part of it is getting people linked to medical behavioral health services that they need. So all of these are going to get wrapped into the enhanced care management. Exactly how it's going to be shaped, it's still being developed, but it's primarily following the Health Home model. So it's going to be the managed care plans that are essentially responsible. They will receive the PMPM dollars, and then they will contract with providers in the community, or if there are not enough providers in the community to do that, they might carry on that responsibility themselves and then try to deliver these additional services to the population.
Thank you. So we're going to do a few more questions, if that's all right with the presenters before we make a few announcements. So one question, I think I'll direct this to Emmeline. So there are many DSRIP and other 1115 waiver innovations in flexible supports. Many settings have been disappointed at the extent to which these have developed into meaningful services to individuals and meaningful contracts and provider entities. In some settings, it seems like the MCOs still experience MLR assessments as a barrier. In others, there are not enough of the non-medical supports being paid for to prompt effective availability. And in others, the needed development of other human services, other human service availability through public partners, In others, the needed development of other human service availability through public partners mechanisms hasn't occurred. Do you have any information about these challenges?
So I am not totally sure what, Jean, you meant by MLR assessments. But what I will say is, I think some of the concerns that you're mentioning are more applicable when we're thinking about the Medi-Cal Health Homes program than about whole person care. I would say, that there were specific mechanisms built into whole person care that were intended to try to overcome some of this. And so I mentioned them before. It's sort of that deliberate inclusion of those partners from different sectors in order, sort of as a condition of funding. I'm scrolling to keep the question up so I can make sure I address. The entire mechanism is focused on really funding the kinds of supports that are not traditionally funded in the medical setting. And so it is a pilot. I think pilots do vary in the extent to which they really put in meaningful partner engagement. That's some of what we're hoping to look at. I mean, I'm aware of where other projects may not have gone far enough. I think it's such a broad question here. Nadi, I don't know if you have strong thoughts to add on. I mean, I would say, you know, part of what we tried to showcase earlier is that there's a lot happening in whole person care related to meaningful provision of services that may not traditionally be provided. A lot happening related to the housing support, a lot happening related to the kinds of benefits assistance that would not be traditionally provided to Medi-Cal beneficiaries. I think a big question, and one thing that a lot of Medi-Cal managed care plans are looking at out of whole person care as they move forward to Pallame is how much it costs, right? And what it may be feasible to provide sort of long-term moving forward. And I think, especially related to housing, right? I think that's a big question that the plans have, I know in initial conversations expressed interest in learning more about as they're formulating their plans moving forward. But at least with this particular pilot, I think the way that funds were allowed to be used to actually focus on infrastructure development, which really takes a very long time, as well as delivery system infrastructure development, was perceived as very helpful.
Awesome. And Nadira, did you want to chime in on that at all?
No, I don't have anything to add. Thank you.
Okay. So I think we have time for an additional question. We still have quite a few. So I'm trying to get a good one. So have you seen either anecdotally or empirically any evidence of WPC providers leveraging these networks to think further upstream? So for example, new investments in health and human services, or advocating for additional state resources?
I think a short answer would be yes. Again, as you might expect, this varies across pilots. Some, you know, really, this was a first foray. You know, you can even, you know, in California, there's considerable county level variation, and counties are sort of at differing stages sometimes in their readiness to address social determinants of health and the kinds of partners that are aligned. Some counties are very sophisticated, and for them, you know, whole person care is just part of a braided funding stream that they're using to really advance work in this area, whereas others, this is sort of first baby steps, and they've been thinking about, you know, where to go next. I'll just say, you know, we have been collecting data through surveys as well as interviews to kind of address this, and please look for future deliverables out of our project that will speak to this sort of at a more systematic level.
Fantastic. Do we want to squeeze in one additional question?
I did see one open question still.
Sure.
That I'll just address briefly. You know, I think David commented most of the benefits of whole person care will be medium and long term and will appear in areas, in potentially in other sectors. And we're aware that that's a limitation of our study, you know, in thinking about the data that's available to us and what the state Department of Healthcare Services is interested in. I think our Robert Wood Johnson Foundation is interested in funding this wrong pocket problem and innovative solutions. And all I would say is, you know, the state, of course, is interested in some of those other impacts, but at the end of the day, they really have to think about impact for the Medicaid program. And so our analyses are unfortunately limited to looking at what we can measure out of the claims data. We are not able to get data to really look at impacts, whether there's corresponding changes in expenditures or what we're seeing in terms of enrollee engagement in some of those other sectors, even though I agree that's important work. It's just not something we've been able to tackle.
Carrington, is there time to answer a question that was in the chat?
Yeah, I think so. Chris, are you okay with that?
Oh,
Yeah,
sorry.
go ahead.
I meant to say Chris and I called on Carrington.
We're twins.
So Sarah said, are the managed care plans held accountable for quality of care / services versus access under these 1115 waivers? So under the whole person care waiver, health plans are partners with the lead entities or the pilots that are running the show. They are not directly held accountable for what's happening under the program. Under the whole person care, the program, the delivery of services is their responsibility. They're not directly reporting in, how they're performing. We are measuring their performance under that particular evaluation. And, but I believe the payment under that program is also on a PMPM basis to the plans. And I don't recall, and maybe Brenna, you remember more, but I don't believe they are penalized if their specific indicators are not, improving.
Yeah, they get payment, but they're not penalized for that.
Right. So they're
Okay. Awesome. Well, thank you so much for Team UCLA introducing us to the study. We really look forward to what comes of it as the supplemental aspect is pretty early on. We'll be sharing these slides and presenter information via email afterward. So hopefully we can keep the conversation going. So in these last few minutes, a few announcements. If you are interested in receiving a certificate of completion for today's Prescribe webinar, there'll be a survey at the end of the session. Please fill that out. We'll also email one to you and get that taken care of for you ASAP. Next slide. And very excited to announce Systems for Action has issued a call for proposals to evaluate the impact of innovative multi-sector solutions to a specific wrong pocket problem. Funded studies will assess the impact of potential solutions on advancing health equity and addressing racial disparities in health and well-being. There will be an informational webinar on March 17th. Please check out our funding opportunities page, systemsforaction.org, to sign up for the informational webinar so you can learn more about this opportunity. There'll be awards up to $500,000 over a 3-year period. We'll give much more detail at the webinar. Proposals will be due June 9th. And of course, we have more of these research in progress webinars, same time, same place. Our next one will be March 24th. We'll hear about a study on the effectiveness of homeless service networks and coordinating services during COVID-19. The following will be April 7th. Learn about we have it duplicated. So the next 2 studies will be part of our COVID-19 cohort of studies. So be on the lookout for more information about these webinars. Hopefully you'll be able to join us. And with that, I want to thank you for taking the time to join us. Hopefully we'll see you again March 24th. Enjoy the rest of your day.